So hello everyone, here we are going to talk about COVID-19 disease which is caused by SARS coronavirus 2. So many of the testing protocols and treatments that I'll be talking about in this video are based on India. So there can be significant differences in the protocols in other countries. And there are a lot of new things coming up constantly, so there can be significant changes in the coming future as well. So SARS coronavirus is a helically symmetrical virus that has an envelope made up of lipid, and this is the reason why when we use alcohol-based sanitizers, these viruses get killed. The receptor for SARS coronavirus 2 is angiotensin converting enzyme 2 receptors, which are mainly present on type 2 alveolar cells in our lungs. And this is the reason why the most susceptible organs in our body is our lungs. The other member of coronavirus family that was responsible for an outbreak in 2012 that was named as Middle East Respiratory Syndrome coronavirus, for that virus the receptor was dipeptidyl peptidase 4. The most important part in SARS coronavirus 2 is the spike protein. This protein is responsible for all the havoc that it has caused. This spike protein has two subunits, S1 and S2. S1 subunit is responsible for its attachment to angiotensin converting enzyme 2 receptors, and S2 subunit is responsible for fusion of membranes of virus and the host cell. The incubation period for COVID-19 disease is between 1 and 14 days with a median incubation period of around 5 days. The gold standard for testing of COVID-19 disease is RT-PCR. Now if it comes positive, it is taken as positive, and if it comes negative, it is a negative. But it is not possible to do RT-PCR in emergency situation because it takes a lot of time. So for such situations we have a rapid antigen test. But the problem with rapid antigen test is that for it to become positive, a very high viral load is required. So sometimes it can give a false negative result. So we can say that if rapid antigen test comes as positive, it is taken as positive. But if it comes as negative and we have high suspicion and the patient is symptomatic, then we can confirm using a RT-PCR. Or if a person with negative rapid antigen test later on develops symptoms, then we can do RT-PCR to confirm our diagnosis. There are two words that are very commonly used: quarantine and isolation. Quarantine means restriction of people that are believed to have been exposed, and isolation is restriction of people that are sick or are positive. There are certain lab abnormalities that we see in COVID-19 disease. First one is decrease in lymphocytes and platelets. There is increase in transaminases like ALT and AST, increase in lactate dehydrogenase, and increase in inflammatory markers like C-reactive protein, ESR, and serum ferritin. Although serum ferritin is increased, but glycosylated ferritin is decreased. COVID-19 disease is a hypercoagulable state, so these markers are also increased in COVID-19 disease. These are fibrinogen, D-dimer, and fibrin degradation products. Prothrombin time and activated partial thromboplastin time is also increased. There are certain markers, and if they are elevated, they denote a poor prognosis. They are procalcitonin, C-reactive protein, ESR, serum ferritin, interleukin 2, 6, 8, 10, tumor necrosis factor alpha, lactate dehydrogenase, D-dimer, cardiac troponin, and pro-brain natriuretic peptide. On CT scan, the most common finding that we see is ground glass opacities. Other less commonly seen findings are crazy paving patterns and air bronchogram. To know the treatment of COVID-19 disease, we have to know a classification of this disease. It is divided into mild, moderate, and severe. If the patient is having just the symptoms of upper respiratory tract infection like running nose, fever, without shortness of breath or hypoxia, then it is a mild disease. If the patient's respiratory rate is more than 24 with breathlessness, or he is having oxygen saturation between 90 and 93 at room air, then he is having moderate disease. And if his respiratory rate is more than 30 with breathlessness, or his SpO2 is below 90, then he is having a severe disease. For mild disease, we can do home isolation for the patient and we can treat the patient there. We have to follow all the basic precautions like hand hygiene. We have to monitor temperature and oxygen saturation of the patient. The patient has to seek medical help if he develops shortness of breath, cough, or fever for more than 5 days. There are certain drugs that are optional that can be given in mild disease, like tablet ivermectin 200 microgram per kg once daily for 3 days, but this has to be avoided in pregnant ladies and lactating women. The other drug that can be used in place of this is hydroxychloroquine. 400 mg twice daily on day 1, followed by 400 mg once daily for next 4 days. Hydroxychloroquine is a drug that can only be used in mild disease. It has to be avoided in severe disease, and it has to be avoided in patients with heart disease or QT prolongation. If the patient is having persistent cough or fever for more than 5 days from the onset of disease, then we can give him inhalational budesonide at the dose of 800 microgram twice daily for 5 days. Coming to moderate disease, a patient with moderate disease will require admission in the ward. We have to give him oxygen support via a non-breathing face mask with a target SpO2 of between 92 to 96%. Now there is a maneuver called awake proning that we do in patients with moderate disease that helps in oxygenation, and it has shown to reduce the mortality. It keeps the alveoli open and helps the patients with breathing difficulty. In this, we alternatively change the position of the patient, first lying prone, then lying right, then sitting up, and then lying left. Ideally, the patient should remain in each position for not more than 30 minutes, and the upper limit for each position is 2 hours. For patients with moderate disease, we have to do monitoring of vitals, serial chest x-rays, monitoring of C-reactive protein and D-dimer every 2 to 3 days, CBC, LFT, KFT every 24 to 48 hours. If the patient is deteriorating, then interleukin 6 and high-resolution CT scan is also to be done. Coming to drugs that are used in moderate disease, we have to give injection methylprednisolone at the dose of 0.5 to 1 mg per kg. It is divided into 2 doses and it is given for 5 to 10 days. Other drug that can be given in place of this is injection dexamethasone with same dose and duration. As I told earlier that COVID-19 disease is a hypercoagulable state, so we give prophylactic anticoagulation therapy. Unfractionated heparin is preferred, but low molecular weight heparin can also be used. Enoxaparin can be used for this purpose at the dose of 0.5 mg per kg once daily via subcutaneous route. Awake proning is not to be done in patients who are pregnant, who are having deep vein thrombosis, any cardiac condition, and patients who are unstable, fracture of spine, pelvis, or femur. It is also not to be done till 1 hour after meal. There are few other drugs that have got emergency use authorization from FDA for off-label use, but many of these drugs have not shown any decrease in mortality for COVID-19 disease. Remdesivir is one such drug that is used for moderate and severe disease. The dose of remdesivir is 200 mg IV on day 1, followed by 100 mg IV once daily for next 4 days. There are certain things to keep in mind while giving remdesivir. It is not to be given in patients with hepatic or renal dysfunction. It is also not to be given to pregnant, lactating women, children who are less than 12 years of age, or patients who are at home or not on oxygen. Hepatic dysfunction can be known by checking the ALT and AST that will be raised by more than 5 times. Convalescent plasma can also be given for moderate disease when high titer donor plasma is available. It has to be given within 7 days and it cannot be given after that. Its dose is 4 to 13 ml per kg and usually it is given at the dose of 200 ml in a single dose. FDA has recently approved a combination of casirivimab and imdivimab. It is approved for adult and pediatric patients with mild to moderate disease who have a high risk of progressing to severe disease or requiring hospital admission. One more combination that has got for emergency use authorization for mild to moderate disease is a combination of bamlanivimab and etesevimab. Favipiravir can also be considered in mild to moderate disease. Coming to severe disease, a patient with severe disease will require ICU admission. If oxygen demand is increasing, then we can start with non-invasive ventilation. In case of no improvement, we can go for high-flow nasal cannula. High-flow nasal cannula is a device that is capable of administering oxygen at a very high flow rate. It is not to be used in patients who are having multiple organ failure, who are unstable, with altered mental status, or having hypercapnia. If all these things are not effective, then we have to go for intubation. In severe COVID-19 disease, monitoring and investigations are almost similar to moderate disease. We have to monitor vitals, serial chest x-rays, C-reactive protein and D-dimer every 1 to 2 days, LFT and KFT to be done daily. In case of worsening, we have to do high-resolution CT scan and interleukin 6 monitoring. Anticoagulation therapy for severe COVID-19 disease is done in the form of injection methylprednisolone with dose of 1 to 2 mg per kg in 2 divided doses, which is higher than what was used in moderate disease. The duration remains same as 5 to 10 days. We have to take supportive measure to maintain blood volume, manage sepsis, shock, and acute respiratory distress syndrome as per protocol. In severe ARDS, we have to use a tidal volume between 4 to 8 ml per kg. The average will be around 6 ml per kg. we have to use a high PEEP between 5 to 15 centimeter of water. Target SpO2 will be between 88 to 95%. We can use remdesivir in severe disease. The dose and duration are similar to moderate disease, as I told earlier. Tocilizumab is another drug that has got emergency use authorization by FDA for off-label use in severe disease. It is an interleukin-6 inhibitor. Its dose is 4 to 6 mg per kg in 100 ml NS over 1 hour. It can only be given in patients with severe COVID-19 disease within 24 to 48 hours. There should be significantly raised interleukin-6 or C-reactive protein. There should be no improvement with steroids and no active bacterial or fungal infection, including tuberculosis. There is a condition called multisystem inflammatory syndrome in children. For the diagnosis of this, the age should be less than 21 years. There should be fever with lab evidence of inflammation requiring hospitalization. There should be involvement of more than 2 organ systems that can be cardiovascular, renal, respiratory, GI or nervous system. There should be no alternate diagnosis, and of course the patient has to be positive for COVID-19 disease. The management of this condition is by fluids, inotropic and respiratory support, thrombosis prophylaxis and extracorporeal membrane oxygenation. Coming to discharge policy, in mild disease the patient can be discharged 10 days after the onset of symptoms with no fever for 3 days. There is no need for negative RT-PCR. Patient is advised for home isolation and monitoring for the next 7 days. For a patient with moderate disease, if his symptoms resolve within 3 days, then his discharge policy is similar to mild COVID-19 disease. In moderate COVID-19 disease, if fever do not resolve within 3 days or if the oxygen demand continues, then we can discharge only on resolution of symptoms and when the patient is maintaining saturation for 3 days. Again, no negative RT-PCR is required for discharge of this patient. Patient is advised for home isolation and monitoring for the next 7 days. But for severe COVID-19 disease, the discharge can only be done after clinical recovery and a negative RT-PCR. I want to briefly touch on vaccines as well. The vaccine with highest efficacy is Pfizer, followed very closely by Moderna. Both of these are mRNA-based vaccines. After that comes Covaxin, which is an inactivated SARS coronavirus 2. And after that comes Covishield, which is an adenovirus vector-based vaccine. A similar Russian vaccine called Sputnik 5 is also coming for use in the market. It is also a similar adenovirus vector-based vaccine and there is no data on its efficacy as of now. You can write your queries and comment down there and I'll be very happy to answer them. Stay safe.